So Dr. Wang wins the award for keeping us on time. Dr. Pardo will not. It is really an honor. It's always fun coming here, not just seeing the community, but seeing colleagues from around. Dr. Pardo wins the award for insanity. So Dr. Pardo did his medical school and a neurology residency in Columbia, came to Baltimore where he did a neuropathology fellowship and then a neurology residency at Hopkins before joining the faculty. He is doubly insane for living through Doug Kerr, Ben Greenberg, and Mike Levy and not being committed to an insane asylum. He was able to hold it all together somehow. And Carlos has spent a career in helping us get more accurate in our diagnoses and has been at the forefront with Philippe Gaillou and others in calling all of us out in the community when we make a misdiagnosis, especially around this very challenging issue of what are called vascular myelopathies. So I'll let Carlos enlighten us.
Thank you so much, Ben. And it's great to be here and coming back to the symposium of the rare neurological and neuroimmunological disorders. I know that you may be a little bit sleepy after a good lunch, right? Okay. I like to learn one thing is, how many of you, when you went to the doctor for the first time, how many of you got the news that this was a stroke of the spinal cord? Can you raise your hand if somebody mentioned a stroke of the spinal cord? Okay, good. So what we are going to talk in the next few minutes is something that is extremely important for everybody, is to understand that blood supply to the spinal cord is critical for the function of the spinal cord. So I will give you a primer on vascular anatomy of the spinal cord. So after these 30 minutes, you are going to be an expert in anatomy of the blood vessels. But the most important is, the message that I want to give you is that not everything that glitters in the spinal cord is a myelitis, because there are other problems that may mimic myelitis. And that's the main message of this lecture. I don't have any disclosure to mention today. However, I need to say that we have done in the past 25 years a lot of work, and it is because the Transverse Myelitis Association that we are able to be here. So everything that you do for the Transverse Myelitis Association, the donations that you are sending at the end of December, all of those are represented in a lot of work that has been presented today and is going to be presented tomorrow, because that represents the work of many people, postdoctoral fellow researchers that are funded by the Transverse Myelitis Association, and actually is translated in the learning and actually the knowledge about what we have about the spinal cord disorder. So thank you so much for that. Second announcement I'd like to make is, in the past 20 years, we have been working at the Johns Hopkins Transverse Myelitis Center. And actually, because the concept of myelitis and myelopathy has been evolving dramatically in the past few years, actually, the Transverse Myelitis Center at Hopkins is having a little bit of a name change. So we are no longer Transverse Myelitis. We are going to be the Johns Hopkins Myelitis and Myelopathy Center. And the reason this changed is because not everything is inflammation, and we are dealing with a lot of spinal cord disorders that mimic myelitis, but actually represent a different problem in the spinal cord, like metabolic myelopathies, like strokes in the spinal cord, and vascular myelopathies. So when we are dealing with the spinal cord, every time we need to understand is what is going on in the spinal cord, is what the problem is. And we deal with issues of immunity, and multiple sclerosis always comes to the table, and neuromyelitis optica comes to the table, and newcomers like MOG comes to the table. So those are autoimmune disorders. But is everything that affects the spinal cord an autoimmune disorder? The answer is no. There are many other disorders. We have trauma, we have infectious disorders, we have post-infectious disorders, and we have this small group of problems that are vascular abnormalities of the spinal cord. And the reason we may need to understand vascular disorders of the spinal cord the importance of that is because if we miss that, we are going to be in trouble. And we are going to be in trouble because misdiagnosis of vascular problem and confusing that with an immunological disease means that we are going to treat a problem in the different approach, an erroneous approach. That means that is mismanagement. So why is that important? Because if we have a spinal cord abnormality, meaning a myelopathy, obviously we need to define if there is an inflammatory process or if there is any vascular component that may be producing this spinal cord abnormality. And the importance of that dichotomy is because the treatment approaches are different. We treat inflammatory myelopathies, myelitis, with some of the tools that we already are familiar with. We treat patients with myelitis with steroids. We treat patients with plasma change, with immunosuppressive therapies, with IVIG. But if we treat patients with vascular myelopathy with any of these, we are going to produce more damage than benefit. So that's extremely important to understand what is the cause of the spinal cord disease. Now, this is a busy slide. The only thing that I want to introduce here as a comment is vascular myelopathy may have two flavors, a green flavor and blue flavor. Okay. The green flavor is acute vascular abnormalities that are called strokes. This is the same as happening in our brain. These are very abrupt, very rapid process that in a matter of minutes produce a damage of the spinal cord because one blood vessel that is coming to the spinal cord gets occluded, there is no blood supply to the spinal cord, and the spinal cord is gone. So that will produce a very rapid myelopathy or very rapid process that is going to produce weakness that is going to be happening very rapidly, is going to produce pain, and is going to produce abnormalities in ambulation, is going to produce sensory problems. The other flavor is a flavor that is not necessarily very quick, but is similarly associated with vascular abnormalities, and these are a little bit more complex. And I'm going to call these vascular myelopathies associated with vascular malformation. So we have a vascular system that is dynamic. So our blood vessels are not like pipes that are rigid and in the house or in a building, pipes that stay there and don't change too much. Actually, our blood vessels are changing constantly. So if you have a small occlusion in a blood vessel, your blood vessels are going to try to rewire in different directions. So the blood vessels in our spinal cord have a lot of capability for rebuilding networks. In other words, if you have an accident, if you are involved in a car accident, and for some reason a small blood vessel in the spine get occluded, other blood vessels are coming to the rescue, and other blood vessels are going to build up the networks. Unfortunately, that may produce long-term consequence in the future, and that may lead to formation of what we call arteriovenous malformations. And occasionally, those problems actually are determined by genetic factors. There are people that are susceptible to develop genetic abnormalities associated with blood vessel supply. So they are more prone to get vascular malformations in the brain, vascular malformations in the spine. So one of the keys when we are dealing with neurological disorders and spinal cord disorders is a very good conversation about what is going on. In other words, I always emphasize to all the residents that are in training and all medical students and everybody in healthcare that the most important part of an encounter with a patient is to listen to the patient and understand what is going on. It's not the MRI, it's not the spinal fluid, it's not the oligoclonal bands. Put those aside. The most important part is to understand what happened in the first several hours of symptoms, what happened in the first part of the disease. In other words, is to understand what is going on with the clinical history, what is going on with the temporal profile, and understand what are the major clues for clinical analysis. So one of the most important aspects in assessment of myelopathies is to understand what is the temporal profile. Is the weakness that a patient experience happening in matter of minutes, like this, or is happening in matter of weeks, or is happening in matter of months? That is actually going to be extremely helpful for diagnosing a myelopathy and establishing a definite diagnosis of an inflammatory myelopathy or a tumor affecting the spinal cord or an infection affecting the spinal cord. So that is very important. So understanding this clinical profile is obviously extremely, extremely helpful. And later will come the MRI, and later will come the spinal fluid analysis and other testing that we are doing. Most of the tests and analysis that we are doing in the clinical profile is to understand where is the location of the lesion and what is the extension and magnitude of the lesion. And that is something that we can get extra help when we do analysis of the MRI. So what I'm going to do in the next couple of minutes is to tell you a little bit about the anatomy of the blood vessels in the spinal cord. So I told you, you are going to be an expert on vascular anatomy of the spinal cord. So the spinal cord is contained here in this container that we call a spine. And the spine here is basically a very good buildup of bones that are protecting very well the spinal cord. And this spinal cord is getting supply from the major pipe in our body that is called the aorta. The aorta is giving blood supply to the spinal cord first because the upper portion of the spinal cord get a very important artery that is called the anterior spinal artery that is basically derived from blood vessels that are called vertebral arteries here in our neck. So that is one of the major components of the blood supply. The other major component is an artery that is coming also from the aorta, is in our abdominal cavity, and is coming to the middle portion of the spine, and is going to provide a major blood supply to the portion of the spinal cord. So let's take a look of the anatomy in cross-section. You already saw a lateral view. You already saw the bone. You already saw the big pipe that we call aorta. This is the cross-section. The cross-section, again, this is the aorta. The aorta is giving at every level of the spine, is giving these two medium-sized blood vessels that are coming and giving more supply to the spinal cord, to the anterior region and the posterior region. But let me explain that in better detail. So this is the CT scan, the representation of one of those CT scans, and you can see the white spine component here, and you can see these are the vertebral bodies. This white structure that looks like a tube is the same as the aorta. So as I mentioned before, there are two major systems, the anterior spinal artery and the spinal artery that is coming here in the abdominal compartment that is called an incubus artery. So those are the two major pipelines that are bringing blood supply to the spinal cord. And why is that important? Because every time that you have a problem in a car accident, your doctors come and take a look of your neck. And one of the problems is if you have some type of flexion extension of your neck, you are at risk of producing a collapse of some vertebral arteries here. And that is going to produce a stroke. If there is a major damage of those arteries, actually, that's going to produce occlusion of the vertebral arteries and are going to produce damage on the anterior spinal system. The same happen or may happen, unfortunately, with the artery that is coming from the abdominal compartment in the aorta that is called an incubus artery. This artery is actually very susceptible to problems, particularly when there are abdominal trauma or surgeons go and try to do some surgical exploration of the abdomen because there is a kidney problem or there is some type of abnormality in the abdomen, and sometimes they hit this artery, and by hitting this artery, they are going to produce a major catastrophe because it's going to produce a complete occlusion and damage of the blood supply to the spinal cord. So these are the two major blood pipelines the anterior spinal artery, the Kiwis artery, that are going to give blood supply to this structure that we call spinal cord. But our body is very clever. Actually, our body functions in the following way. We have, again, a system that is providing the blood supply from above, a system that is providing blood supply from below, and that is to maintain the blood supply of the entire spinal cord. But at the same time, our body is extremely very well designed, and in the same way that there is a vertical system, anterior spinal artery and the artery that are coming from below, there is also a horizontal system. So every level of our spinal cord has a blood supply that is provided by different arteries that are also coming from the aorta at every level. So there is a vertical system, there is a horizontal system, and the main goal is to maintain the normal function of the spinal cord. So if there is an injury in any artery associated with the vertebral artery, obviously the major damage is going to be in the cervical cord. If there is any damage of this artery in the abdomen, there is going to be a major problem in the thoracic or lumbar spinal cord. Why is that important? It's important because a spinal cord is subject to damage when there is abnormalities in blood supply. This is a 16-year-old patient that came to the clinic several years ago. This was a student that was exercising and doing gymnastics and enjoying life, and experienced some damage, flexion extension in the neck, and that led to damage of the vertebral artery, something that we call vertebral artery dissection. This patient came to the emergency department, immediately was evaluated because the patient was experiencing upper extremity numbness and weakness, and everybody got in a panic, and the MRIs were done, and initially the diagnosis was a myelitis. And later, when we listened the story that this patient had been exercising and doing gymnastics, we realized that is not myelitis, and that is probably a vertebral artery. And the fact is, the imaging of the spinal cord show that the lesions were somewhat similar to myelitis, but some of the lesions actually were in areas of the spinal cord that we call arterial territory. So this patient, that was a young patient, actually was diagnosed with a stroke of the spinal cord. And one of the other clues that we have in this type of patient is that the symptoms happen abruptly. The other situation that we have frequently is that, remember, we have a blood supply from above, we have a blood supply from below. And occasionally, some patients experience problems like low blood pressure. And this is an example that we frequently experience, unfortunately, is patients that are experiencing cardiovascular problems, go and experience a heart attack, the blood pressure goes down dramatically. Well, guess what? The blood pressure is not able to provide enough blood supply to the point that there are areas of the spinal cord that are left without blood supply. So the middle portion of the spinal cord is going to be experiencing something that we call ischemia. And that ischemia keep growing if there is no enough blood pressure support, and that eventually is going to produce a complete damage because there is lack of blood supply in the middle of the spinal cord. So we are frequently in trouble when we experience problems with patients that have cardiovascular problems or have surgeries in the abdomen, and there is a collapse or there is damage of the blood supply provided by our arteries coming from the abdominal compartment, and portion of the spinal cord experience extensive damage. And that obviously mimic myelitis, but unfortunately that is not necessarily a myelitis, that is a stroke that is going to have actually major consequence in function for those patients. So, summary, many areas of the spinal cord are going to be subject to these abnormalities in blood supply, and most of the abnormalities are in gray matter structures, and that's the reason the motor neuron that is localized here and is the main cell that produces function in the spinal cord motor function is going to be damaged, and the patients are going to be paralyzed. So I'm going to give you an example of what we have seen in our experience in our center related with evaluation of these patients. So what we did actually in the past few years was to analyze the casuistic of patients that came to our clinic with the diagnosis of myelitis. And this is actually one of the take-home messages. So if we take all the patients that come to the Johns Hopkins with the diagnosis of transient myelitis, guess what? Almost 1/3 of the patients don't have transient myelitis. And this is the total population between 2010 and 2018 of patients that came to the Johns Hopkins transient myelitis. We have more than 800 patients coming with that diagnosis. So we concluded that a good percentage of patients have MS or neuromyelitis optica or infections or other type of disorders that were associated with inflammatory pathology of the spinal cord. So technically, those were inflammatory myelopathies or myelitis. However, almost 32% of the patients didn't have that. And when we analyzed those patients, we encountered that a good percentage of those patients actually had strokes of the spinal cord or chronic abnormalities in the vascular supply of the spinal cord leading to ischemic damage. So in summary, almost 2 of 10 patients that came to Johns Hopkins Transient Myelitis Center actually had vascular abnormalities rather than myelitis. So it's almost 20% of the population. And that actually is represented here. So this is the age distribution of those patients, and pay attention to the blue blocks. So this is the group of patients between age 0 and 19. This is the group of patients greater than 60. So you can see that every age group had a good representation for strokes of the spinal cord or vascular abnormalities in the spinal cord. So in other words, we need to be aware that the strokes happen at any stage of life, and strokes are part of the differential diagnosis when patients show up to the clinic with symptoms suggestive of myelopathies or myelitis. Another group that is becoming quite evident is the group of patients that have chronic vascular problems. So the group that are associated with the strokes are mostly acute myelopathies that we realize that are associated with strokes or blood supply injury. But the other group is a group in which we see frequently patients that are above age 50 that have this type of chronic evolving abnormalities that we call longitudinal extensive myelopathies. Most of these patients actually had central cord disease, and many of these patients are later diagnosed with what we call dural AV fistulas or arteriovenous malformations of the spinal cord. And I'm going to explain that in more detail. So one of the things that we came with the analysis of all of these patients is way to differentiate what is myelitis from vascular abnormalities. And we analyzed the details of the clinical history of all of these patients, and this was published by one of our fellows, Dr. Barreras, who did an analysis of more than 500 patients and did a very thorough statistical analysis, and by modeling the clinical presentation and data obtained from these patients, concluded that in many ways, there are good approaches to differentiate myelopathies associated with vascular problems from myelitis. And for example, in terms of the clinical profile, it's very clear that many myelopathies that happen over age 50 and 60, or when patients are getting older and older, are very concerning to be associated with vascular abnormalities. But also, it's very interesting to see that the initial presentation of the symptoms is a clue to determine if a patient is suspicious to have an acute stroke or is suspicious to have a myelopathy. And the hyperacute presentation actually is one of the clues that in statistical models prove to be very efficient in differentiating vascular strokes from myelitis. And this is important because it's very clear that when we are dealing with patients that have acute myelopathic symptoms like weakness and sensory abnormalities, the first thing that we need to think about is the potential presence of an acute stroke, or if this is a child that is between age 1 or 15 or 20, obviously the diagnosis of acute flaccid myelitis needs to be entertained. But if the profile, the temporal profile is relatively of days or even months, there are other diagnoses like transverse myelitis or neurosarcoidosis, MS or neuromyelitis optica. So in other words, the clue that there is a hyperacute onset of symptoms is in favor of acute strokes or acute flaccid myelitis. And in the same way, when we are dealing with patients with chronic myelopathies, one of the aspects that we need to establish in the differential is the possibility that this patient may have a vascular abnormality like dural AV fistulas. Now, I'm going to talk about those in more detail because the MRI features and spinal fluid features may help us to differentiate those disorders as well. In terms of MRIs, when we encounter MRIs that have no evidence of gadolinium enhancement during the acute phase or are read as normal, we need to be very suspicious that those patients may have strokes. In other words, patients come to the ER, acute neurological symptoms or hyperacute neurological symptoms, the MRI is done, and the doctor say, wait a minute, there is nothing in the MRI. That actually is very concerning for a potential stroke of the spinal cord. So MRI is helpful, particularly when there are some clues like lack of gadolinium enhancement or longitudinal extensive myelopathies. And in the same way, the spinal fluid may provide clues. For example, when the spinal fluid show evidence of oligoclonal bands, that is a negative predictor for a vascular myelopathy. In other words, it's a positive predictor for a potential inflammatory myelopathy. So oligoclonal bands, in our view, is a very good tool to put the diagnosis on the side of inflammatory myelopathies. Now, let me give you some examples. I'm going to skip these because I'm running out of time, but I want to give you examples why it's important to establish this diagnosis of vascular myelopathies. The most important is we are able to treat some of those disorders. So if this is a stroke of the spinal cord, and this happened because the surgeon went to do a surgery in the abdominal region and cut the blood supply, is something that we are not able to fix. But if there are situations in which there are identified causes of vascular abnormalities, some of them may be fixed. So what we know is that strokes in older adults are frequently associated with atherosclerosis, hypertension, and diabetes. So if we have an adult with those risk factors, we can target those risk factors. If we have young people that have a stroke because there are trauma or there are other type of coagulation disorders, we may target those disorders, and we may try to prevent the onset of more strokes. Now, this is an example of something that is very fascinating. This is a patient that had a herniated disc, and the herniated disc went anteriorly and collapsed one of the blood supplies facilitated here in the segmental artery. Actually, this is something that a neurosurgeon can fix. And this patient actually had a myelopathy, initially diagnosed as myelitis here, but later, after we analyzed the imaging, we found that this patient had an occlusion of one of the segmental arteries, and that had produced a stroke of the spinal cord, and this patient actually went to surgery, and we prevented that this patient have more damage of the spinal cord by separating this small artery from the herniated disc. And in other words, there are things that can be fixed when we are able to identify structural abnormalities on the spinal cord supply. The same happened with arteriovenous fistulas. What are arteriovenous fistulas? Arteriovenous fistulas are abnormalities that are present frequently in older adults, frequently in males, and these are chronic evolving abnormalities. What happens is the blood supply that is given to the spinal cord by arteries and veins, and this is the normal anatomy, unfortunately may be disturbed by trauma or by genetic abnormalities, and occasionally those blood vessels, arteries and veins, get together and establish an abnormal network, And by establishing that abnormal network, there are going to be a development of very abnormal blood vessels, and that can be fixed surgically or can be fixed with interventional radiology. And these are different flavors. These are patients that came to clinic and they were found with longitudinal extensive abnormalities. Some of these patients have already very clear signs in the MRI of blood vessel abnormalities. And in those cases, we went and did an angiogram. We identified the source of the fistula, and we were able to fix that fistula. Fistulas happen frequently in the thoracic region and lumbar region. Occasionally may happen in the cervical region, but fistulas are actually very easy to identify when the physician is suspicious about that. The problem is that fistulas, for example, are present in subjects that are susceptible to fistula, particularly older men. And in many of those subjects, when the physician is treating the problem, for example, with IV steroids, some of the steroid treatment actually increase the symptoms. One of the problems that we encounter analyzing the patient population that we had is that the majority of our patients, there was a good percentage of patients, almost 44% of the patients, that have interventions with immunosuppressive medication, and even some of them underwent long-term immunosuppressive regimens with the belief that was a myelopathy, and actually that was a mistake from a medical point of view. So identifying a dural AV fistula is probably a good step to treat the problem, and we know that we are able to treat the problem and improve the quality of life of some of these patients. This is a busy graphic, but let me show you what it represents. This represents the graphic of the dysfunction in mobility, dysfunction in bladder function, dysfunction in bowel function. And what this represents is when the patient was diagnosed and after treatment, the patient improved in the scale of outcome. In other words, the majority of these patients are able to be rescued and improved in terms of function. And so this is something that is extremely important from assessment of patients with myelopathies, is to be aware about vascular problems and make sure that there is no misdiagnosis and identification or misidentification of myelitis instead of vascular myelopathies or vice versa. So I want to finish here with the following statement. The work that we do at the center at Hopkins actually is the result of a collaboration with a lot of colleagues at Hopkins and outside of Hopkins. We have a very close collaboration with the Kennedy Cricket Institute, who is very helpful for evaluation and treatment in rehabilitation, because that is actually extremely important for vascular myelopathies as well. And we have a very good network of collaboration with the Transverse Myelitis Center, with Ben Greenberg, and with other colleagues around the country. And that is something that is extremely important for all of us. But in our institution, all of the work that we have done is the result of work of many people. And in the terms of vascular myelopathies, I want to emphasize Philippe Galliou, who is a neuroradiologist who actually is a master of identifying all of these vascular abnormalities. We have a lot of people working in our center, and one of the Transverse Myelitis Association fellows, Dr. Alwyn Murphy, actually has already 2 papers on route of publication just describing the abnormalities associated with vascular myelopathies. I will stop here, and I need to say thank you for all the support that you gave to the Transverse Myelitis Association and to our centers. And I don't think I have too much time for questions. And
we have time for 2.
2 questions. Okay, go ahead. 2.
Anybody has a question?